Before we begin, just a quick professional disclaimer for you. This deep dive is designed as a high-yield conceptual framework. It's based directly on Simpson's Forensic Medicine, Chapter 22, Principles of Toxicology. So if you are a medical student, a junior doctor, or a senior clinician, this audio exploration is here to support and reinforce your reading. It's to help build your clinical and medico-legal reasoning and to prep you for exams. But, and this is important, please remember, it is not a replacement for reading the actual textbook chapter.
Yeah, that is a really crucial point. You should use this discussion to anchor the core concepts and build that pattern recognition. But you absolutely must open the text yourself to solidify the granular details.
Right. So let's dive into the material. The central theme of this chapter really struck me, actually. It's this idea that not all causes of death are visible to the naked eye. Sometimes there is no bruise, there's no fracture, no tissue tear. There is literally only a profound biochemical disruption. So our mission in this deep dive is to explore the invisible chemistry of death and to understand how forensic medicine attempts to transform uncertainty into clarity through toxicology.
Exactly. And while toxicology is undeniably a powerful diagnostic tool, reading through these principles reveals that it requires immense clinical restraint. Because a number generated by a laboratory machine means absolutely nothing in isolation. The mere presence of a substance doesn't automatically explain a pathological mechanism. A concentration must always, without exception, be interpreted within the clinical context, the medical history, and the physical scene findings.
Okay, let's unpack this. Because the real-world impact of drugs, and how we legally interpret them, often looks very different from the stereotypes. When we think of forensic toxicology, it is easy to picture the expected scenarios, right? The heroin-dependent intravenous drug user, or maybe the intoxicated driver arrested behind the wheel. But the text details a much more tragic clinical reality right at the start. It discusses cancer patients who are dying without adequate pain relief, simply because doctors are terrified, right, like the classic spy movies.
Exactly. Those are incredibly rare. The skill you need for your exams and your clinical practice is in recognizing the complications of commonly abused drugs. We're talking about stimulants, opiates, and standard prescription medications, and understanding what the laboratory measurements actually signify in a real physiological context.
That brings us to how the text breaks down the core principles of toxicity and receptors. There is a distinction made early on between terms we often use interchangeably on the wards. Toxic generally means a substance causes illness, but poisonous specifically implies that ingestion will cause death. And historically, there was a really heavy reliance on the concept of the LD50, the dose of a drug that is mathematically lethal to 50% of the subjects who take it. But the text seems to suggest this is falling out of favor.
It is. It's becoming a rather outdated concept in modern forensic practice, and there are sound physiological reasons for that shift. The primary issue is bioavailability, which is entirely dictated by the route of administration. Consider an intravenous injection. If a drug is given IV, it is 100% bioavailable. The entire dose enters the systemic circulation immediately. So if a patient takes 10 milligrams of morphine IV, you expect a peak plasma concentration of roughly 100 to 200 nanograms per milliliter.
But oral administration is a completely different story.
Completely different. If you give that exact same 10 milligram dose orally, the peak plasma concentration is only a fraction of that. And that's due to incomplete absorption and first-pass metabolism in the liver. Furthermore, the LD50 varies wildly between animal species because of anatomical and metabolic differences. Courts in many jurisdictions have actually recognized this now. They've ruled that extrapolating animal LD50 data to humans is scientifically unreliable for proving causation in a court of law.
Here's where it gets really interesting. The textbook emphasizes that toxicity isn't just about a drug being present in the system. It's largely about how well that drug fits the target receptor. For example, it notes that oxycodone is many times more powerful than morphine on a weight-for-weight basis. And my understanding is that this essentially comes down to the physical fit of the molecule on the more receptor.
That physical fit dictates the clinical toxicity. It is all about binding affinity. And you also have to account for genetic mutations at the receptor level. Pathology has identified over 140 different mutations within the human Mu receptor alone. These mutations physically alter the three-dimensional shape of the receptor. As a result, some drugs fit much better and others fit much worse.
Thinking about the clinical application for you there, if you have a patient asking for stronger pain medication, your immediate assumption shouldn't always be that they are a drug-seeking addict. They might simply possess a genetic mutation that alters their Mu receptor shape. preventing their current pain reliever from binding normally. It could be a purely physiological issue rather than a behavioral one.
That is an excellent clinical anchor. And it highlights exactly why we need strict definitions when discussing drug behaviors and physiological adaptations. Let's look at tolerance as defined in the text. Tolerance occurs after chronic exposure, where increasingly large doses are required to produce the same physiological effect. The mechanisms aren't entirely understood. It is far more complex than just basic receptor downregulation. The escalation of the required dose can be massive, sometimes increasing 100 to 1,000-fold.
And it happens fast, right?
Remarkably fast. Cocaine tolerance, for instance, begins to emerge at the cellular level after the very first dose.
Wow. Then the chapter moves into dependence, which obviously goes hand in hand with tolerance. It uses the DSM-V criteria to draw a clear line between substance-induced disorders and substance use disorders. From what I read, substance-induced disorders are the direct, acute symptoms occurring during or immediately after taking the drug. But a substance use disorder is diagnosed based on a pathological set of behaviors continuing despite the obvious problems the drug is causing.
Yes, and the DSM-V breaks those pathological behaviors down into four main categories, which are vital for your clinical reasoning. First is impaired control. This means taking more of the substance than intended or failing in attempts to quit. Second is social impairment, neglecting obligations at work, school, or within the family. Third is risky use, continuing to use the substance in physically dangerous situations, such as driving, despite full awareness of the potential harm.
And the fourth category.
The fourth encompasses the pharmacological indicators, which are the development of tolerance and the presence of withdrawal symptoms. The severity of the disorder, whether it is mild, moderate, or severe, depends entirely on how many of these specific criteria the patient meets.
I was also intrigued by the section on drug idiosyncrasies. These are described as unanticipated reactions, mostly allergic in nature, which can range from mild symptoms all the way to full anaphylactic shock. The text mentions a debate in pathology, spanning more than half a century, about whether the pulmonary edema often seen in fatal heroin abuse might actually be a type of hypersensitivity reaction.
It is a fascinating pathological puzzle. It has never been conclusively proven to be an allergic reaction, but the fact that the debate is ongoing highlights how much of the pathophysiology we still have to uncover. But beyond unpredictable idiosyncrasies, we have highly predictable pharmacokinetic interactions. If we connect this to the bigger picture, we need to look closely at the enzymatic level, specifically the cytochrome P450 hepatic enzymes.
The CYP enzymes. I spent a good amount of time on this section because it seems like a massive potential pitfall in prescribing.
It is a frequent source of fatal drug interactions. The chapter uses a very clear clinical example to illustrate this. Methadone is metabolized in the liver by the enzyme CYP3A. Taking methadone actually induces or increases the body's production of CYP3A. If your patient is concurrently taking carbamazepine, which relies on that exact same enzyme for metabolism, their carbamazepine levels might drop unexpectedly low because the surplus enzymes are rapidly breaking it down. But consider the opposite scenario. That same methadone patient takes diltiazem, which is a known CYP3A inhibitor.
So the diltiazem effectively blocks the enzyme, meaning the methadone won't be metabolized at all. It would just build up in the system to unexpectedly high and potentially dangerous concentrations.
Exactly the case. It creates this enzyme traffic jam. Grasping that concept is vital for avoiding iatrogenic harm. The chapter also outlines another critical physiological interaction regarding the HERG channel in the heart. This is the slow, repolarizing potassium conductance channel. Its function is to dictate cardiac repolarization, basically the resetting of the electrical system before the next heartbeat.
And the text points out that if a drug inadvertently binds with the HERG channel, it disrupts that normal cycle of potassium returning to the cell, which leads directly to fatal cardiac arrhythmias.
Unanticipated HERG channel interactions are actually the leading cause of pharmaceutical drug recalls today. The physiological disruption is that profound. To give you a historical anchor for this concept, modern research has revealed that arsenic is a potent HERG channel poison. This specific potassium channel interaction might very well explain the cardiovascular collapse and death of Emperor Napoleon.
That historical context definitely makes the underlying physiology much easier to remember. I want to shift gears here to how pathologists actually go about testing the body. The media has created this illusion, the book calls it the CSI effect, that detecting a drug tells you everything about the crime. But the text is explicit. The mere presence of a drug, even in massive quantities, only proves exposure. It says absolutely nothing about toxicity, intention, or motivation.
That is perhaps the most important medical legal principle in the entire chapter. We could demystify this by looking at localized testing. Imagine you are reviewing a scene report. A left-handed individual with known heroin dependence is found dead, and there is a fresh needle mark in their left antecubital fossa. Intuition might suggest that testing the skin tissue directly at that puncture site or taking vaginal or rectal swabs in cases of suspected internal concealment would definitively prove the route of administration. It does not.
Because once a drug enters the bloodstream, it circulates systemically. Finding cocaine or heroin in mucosal tissue simply means the systemic circulation persisted after the drug was ingested or injected. It doesn't prove the drug was initially absorbed through that specific localized route.
That is the physiological reality. The blood carries the evidence everywhere, which naturally leads to the complexities of drawing blood in the mortuary during an autopsy.
So what does this all mean for autopsy blood sampling? I found this part deeply counterintuitive. The text states that the anatomical site of the postmortem blood draw matters immensely for the results.
It matters because a cadaver is not a living organism with circulating fluid. After death, the concentrations of weekly basic drugs are often higher on the left side of the heart than on the right side. Furthermore, concentrations in the heart are generally much higher than those found in the peripheral vessels, like the leg. As the chapter carefully notes, post-mortem blood measurements almost always exceed ante-mortem levels. Autopsy blood isn't living blood. The text describes it as a reddish clumped liquid. Because the fluid dynamics have completely ceased, it makes zero scientific sense to discuss a therapeutic range in a cadaver.
There's a case in the text that perfectly highlights why this context is everything. It details a man who had a record-breaking blood cocaine level over 35,000 nanograms per milliliter, but the autopsy revealed his actual cause of death was a .45 caliber bullet that had traversed his brain. It's a stark clinical reminder that massive toxicological presence does not equal cause of death.
A very effective example of why scene correlation is mandatory. Let's delve into the specific testing matrices outlined in the chapter and their medico-legal pearls. Blood and urine are the most common starting points.
I was reading the section on blood testing, and it highlighted a distinction that could easily catch someone out in a legal setting. It says hospitals test plasma for living patients, but mortuaries test whole blood for autopsies. Why does that slight difference matter so much legally?
It comes down to water content. Plasma actually contains 10 to 15% more water than whole blood. Because ethanol is highly water-soluble, plasma ethanol concentrations will inherently read 10 to 15% higher than corresponding whole blood concentrations drawn from the exact same patient at the exact same time. The seemingly minor physiological detail is enough to wrongfully convict or completely exonerate someone accused of driving under the influence if the lawyers and clinicians don't understand the testing matrix.
That is a massive distinction.
It is. Also, it is worth noting the laboratory shift mentioned in the text. Thanks to cheaper gas chromatography and mass spectrometry technology, laboratories are moving away from initial urine screening in favor of screening whole blood directly. Cardiac blood is highly sensitive for this initial screening because drug concentrations artificially increase faster in the heart post-mortem, but peripheral blood must be used to confirm the true systemic findings.
The chapter also covers vitreous humor, the fluid inside the eye. It describes it as an isolated matrix, somewhat protected from the external environment.
That anatomical isolation makes it incredibly valuable. It is a highly stable fluid, making it perfect for bodies found after extended environmental exposure or in drowning cases where blood might be diluted. Crucially, testing vitreous alcohol concentrations helps pathologists distinguish between actual ante-mortem alcohol ingestion and the post-mortem alcohol formation that naturally occurs during bacterial decomposition.
Then there is hair analysis. The text presents it as a permanent timeline because drugs and their metabolites become trapped in the hair shaft and remain stable indefinitely. That seems legally invaluable. It could be used to prove a patient's historical compliance with a prescribed medication. Or, conversely, it could disprove a claim of acute drug-facilitated sexual assault if the segmented hair analysis reveals the person is actually a chronic, long-term user of that specific substance.
The timeline hair provides is unparalleled. Moving to solid organs, the liver is crucial for identifying highly protein-bound drugs such as tricyclic antidepressants. But there is a vital anatomical caveat the pathologist must observe. After death, most drugs readily diffuse directly through the stomach wall and into the adjacent right lobe of the liver. Because of this post-mortem contamination, accurate toxicological analysis requires the pathologist to sample exclusively from the left lobe of the liver.
The stomach contents section had a concept that really challenged my assumptions. The text mentions ion trapping, where intravenously injected drugs like cocaine and morphine can actually end up in the gastric contents. How does a drug injected into a vein end up in the stomach?
It is a fascinating piece of physiology. The stomach is a highly acidic environment. Many drugs, like basic alkaloids, circulate in the blood unionized. But when they cross the gastric mucosa into the acidic stomach, they gain a proton. They become ionized or charged. Once charged, they can no longer cross the lipid membrane back into the blood. They are literally trapped in the stomach.
So they just accumulate there.
Yes.
Okay.
Additionally, high stomach levels might just be an artifact of intrahepatic circulation, essentially. The liver processing the drug, dumping the metabolites into the bile, which then empties directly back into the gastrointestinal tract. So finding a drug in the stomach does not definitively prove the deceased swallowed a handful of pills.
That makes the interpretation of these results incredibly complex. And that leads directly into what the chapter calls the toxicologist's nightmare post-mortem redistribution, or PMR.
PMR is the single biggest confounding factor in forensic toxicology. During life, drugs are stored in deep body compartments, fat, solid organs, muscle tissue. As the body decomposes, which begins at the cellular level immediately after death, the cell membranes break down. Those stored drugs are released and follow a concentration gradient back into the pooled, stagnant blood.
Then there are mechanical factors too, right?
Yes, as noted in the chapter's anatomical diagrams, terminal aspiration of stomach contents into the lungs frequently occurs at the time of death. Drugs sitting in the lungs can then easily diffuse directly into the nearby heart. This is why blood drawn from the iliofemoral vessels in the leg is generally considered much more reliable for testing than cardiac blood.
The fentanyl study cited in the chapter perfectly illustrates the danger of PMR. They looked at 20 medical examiner cases. In a subset of 7 cases, femoral blood was drawn shortly after death, around 4 hours, and then another sample was taken at the formal autopsy, around 21.6 hours. In 4 of those cases, the early 4-hour sample showed none detectable for fentanyl. But the autopsy sample drawn just 17 hours later showed massive concentrations, up to 52.5 micrograms per liter.
That study proves why isolated numbers are dangerous. A careless pathologist, looking only at the isolated autopsy measurement, could wrongfully declare a fatal fentanyl overdose when the drug wasn't even circulating in the blood at the time of death.
To close out the interpretation section, the text touches on genetic polymorphism, showing that high drug concentrations don't always mean the person intentionally took an overdose.
Sometimes, the patient simply lacks the genetic ability to metabolize a normal therapeutic dose correctly. The chapter details a profoundly tragic case of a newborn infant who died from morphine poisoning via breast milk. The mother had been prescribed codeine for standard post-labor pain. Codeine is a prodrug. An individual with a normal genetic complement converts roughly 10% of that codeine into active morphine in the liver.
But this specific mother was an ultra-rapid metabolizer of the cytochrome P450-2D6 enzyme.
Because of that unique genetic anomaly, her liver converted far more than the standard 10% of that codeine into morphine. She lethally poisoned her infant through her breast milk, despite never taking an excessive or illegal dose of the medication herself. It is a sobering reminder of why forensic toxicology demands immense restraint. Every laboratory number must be translated into physiological meaning without exaggeration. It must be continuously cross-referenced with scene findings, medical history, and the unique genetics of the deceased.
Absolutely. To help you anchor these frameworks before your next ward round or exam, let's run through 5 rapid, single best answer recall prompts based directly on the text we've just covered. I'll ask the question, and I want you to take a brief pause to think about your answer before we reveal it. Question 1. What is the expected physiological difference in ethanol concentration between a hospital plasma sample and a post-mortem whole blood sample taken from the same individual? Take a second.
Right, so plasma ethanol concentrations will inherently read 10 to 15% higher than whole blood simply due to the higher water content in plasma. If you need to review the mechanisms of testing matrices, head back to that specific section in the chapter.
Question 2. To avoid analytical contamination caused by post-mortem diffusion from the stomach, which specific organ section should the pathologist use for toxicological analysis? Think about the anatomy.
The left lobe of the liver. The anatomy in the specific testing matrices section visualizes how diffusion directly affects the right lobe.
Question 3. A patient dies unexpectedly, and autopsy blood reveals toxic methadone levels. The history shows they were concurrently taking diltiazem. What is the precise pharmacokinetic mechanism at play here?
Diltiazem acts as an inhibitor of the CYP3A enzyme. This prevents the normal hepatic metabolism of methadone, causing it to build up to fatal levels. You can review enzyme inducers and inhibitors in the definitions section under drug interactions.
Question 4. What physiological phenomenon explains why an initial post-mortem blood draw might show 0 fentanyl, but an autopsy sample taken from the same site 17 hours later shows massive, potentially fatal concentrations?
Post-mortem redistribution, or PMR. As cellular breakdown begins, the drug releases from deep tissue compartments back into the stagnant blood. This is heavily detailed in the interpretation section.
And finally, question 5. A mother taking normal therapeutic doses of codeine tragically passes fatal morphine levels to her infant via breast milk. What underlying mechanism explains this outcome?
Genetic polymorphism. Specifically, she was an ultra-rapid metabolizer of the cytochrome P450-2D6 enzyme, converting an abnormal amount of the prodrug into active morphine.
Excellent.
Before we finish, this reading raises an important question for you to mull over. If post-mortem numbers can fluctuate so wildly based on the exact hour the blood is drawn, the specific anatomical site it's drawn from, and the deceased's unique genetic metabolic rate, how many historical criminal convictions based purely on a toxicologist stating a single number was in the lethal range might actually be mathematically and scientifically flawed?
That is a clinical reality that definitely requires restraint. Thank you for taking this deep dive with us. We highly encourage you to open Simpson's Forensic Medicine, Chapter 22, to consolidate all these frameworks for yourself. See you next time.